Good? Okay, great. Hello, everyone. Good afternoon. I have the pleasure of introducing today's grand round speaker, Dr. Marcio Soares. Dr. Soares earned his medical degree at the Instituto Universitario de las Ciencias de la Salud Fundación Barceló in Buenos Aires, Argentina. He completed residency at Texas Tech University Health Sciences Center in Amarillo, Texas, and his fellowship was completed in geriatrics and palliative care medicine at UM-Jackson. Dr. Soares wears many hats in the UHealth system. These include Associate Chief Medical Officer, Chairman of Utilization and Management Committee, and he was previously the Medical Director of the Pharmacy and Therapeutics Committee. He has earned awards such as the Dean's Letter of Recognition for Patient Care, and Dr. Soares is currently the Interim Chief of Geriatrics and Palliative Medicine. Please help me in welcoming Dr. Marcio Soares today as he speaks about treating cancer-related pain in the opioid crisis.
Thank you. Thank you, everybody. Thank you for having me. So we'll get started with the presentation. The first learning objectives, we're going to look at the epidemiologic data on the opioid crisis and the impact of our prescribing patterns, illustrate the strategies for treating cancer-related pain, and identify opioid misuse and how effectively to manage that. So first we're going to look at the classification of opioids, and you can see here there's a poppy seed and it's scored and the latex is dripping from there. 8 to 14% of that latex converts into opium and creates morphine. So we have the naturals, which are morphine and codeine, semi-synthetics like hydrocodone, hydromorphone, oxycodone, oxymorphone, and heroin. And the synthetics, which are fentanyl, methadone, and tramadol. So the opioid crisis. From the year 1999 to the year 2017, more than 700,000 deaths have occurred due to drug overdose total. Of those, 399,000 were due to opioids. In the year 2017 alone, 70,237 drug overdose deaths in the United States. Of those, 68% involved opioids, both illicit and prescribed, and 38% of those were prescribed only. 2007, the number of opioid deaths was 6 times that of 1999. On average, every day, 130 Americans die because of opioid overdoses, and 46 of those are due to prescription medications, prescription opioids. So how did the problem happen? And it happened in 3 waves, and you can see here in the graph. The first wave started in the 1990s when we had the thought process that pain as the 5th vital sign. With that, there was a lot of loosening of our prescription strategies and consequently an increase in prescription opioid medications, leading to increase in opioid deaths and prescription opioid deaths that happened began to be noticed in the year 1999. When that happened, we tightened up the way that we were prescribing the opioids, which led to an increase that was noted in 2010 with a rapid increase in heroin, as you can see here, that began around 2010 and continued to increase until reaching a steady state in 2017. The third and last wave has been in 2013, and there's a lot of things being talked about right now. And actually, this weekend, 60 Minutes had an expose on the use of the synthetics and specifically on fentanyl and how that has increased the number of deaths. And you can see here the significant increase that happened began around 2013 and has had the major effect that it has now. So drugs involved in U.S. overdose deaths from 2000 to 2017, and you can see that there's a big distribution. It's pretty similar to what it was before, to the previous graph, but this one also has the illicits here and the deaths associated to that. Okay. Because I do utilization, I look at all the ED visits for non-fatal overdose use and hospitalizations. This, as you can see, the numbers for all kinds of drugs are still pretty high. There's not that much related to opioids in general, and the majority of them are illicit. So when it comes to ED visits specific for overdose and specific for prescriptions, it's not that high of a number. So when does prescribing become a problem? More than 191 million opioid prescriptions were dispensed in America in the year 2017. Healthcare providers in the highest prescribing state of Alabama wrote for prescriptions 3 times for every patient, and the lowest prescribing state was Hawaii. The most common drugs involved in prescription opioid overdoses were methadone, oxycodone, and hydromorphone. The population that is growing the fastest and the significant increase has been the population that I deal with the most, which is 65 years and older. Overdose deaths is higher on non-Hispanic whites and American Indian compared to non-Hispanic blacks and Hispanics. So as you can see here, there's not a very good distinction when it comes to the map and geographic location. There are specific pockets where you see a lot of overdose deaths, but there is not a very even distribution when it comes to states and when it comes specifically to counties. This was data from the CDC in 2017. Also, when we distribute based on the size of those geographic locations, you can see that it's pretty even here for the majority of those cases. This graph is also comparing 2016 to 2017, where you don't see a significant increase or impact when dealing with specific population locations. So, prescribing rates, the biggest and the highest rate was in 2012, where we had over 255 million prescriptions for opioid medications. Prescribing rates per 100 people, 81.3 prescriptions for every 100 people in the United States. The prescribing rates, as you can see here, like we talked about, it continued to decrease. Starting in the year 2010 to 2012, you start seeing where the peak starts hitting, and it slowly has been coming down. So as you can see here, we're slowly improving on our prescription patterns. The problem has been in this area here. So high dose prescriptions continue to remain high, and the decrease in high prescription dose drugs is not decreasing at a fast enough rate. We define high prescription drug doses by 90 milliequivalents of morphine or morphine equivalents a day. So anything above that is considered high dose. So what does Florida have to say about this? And we all know the HB 21 law that's been put in place. It was signed by Governor Rick Scott in March 19th of 2018. It required the Department of Health to maintain an electronic system to collect and store controlled substances dispensed. And we all know the E-Force, and it's something that we need to do on a regular basis. It requires that prescribers or a designee must consult that database every time and for every patient before writing the prescription. So the thing that I wrote, and the reason why I highlighted in red the designee is that designee must be assigned on the E-Force website. So I can't say my resident is my designee and he's going to look at it. If my resident does the E-Force and writes the prescription and looks at E-Force, I still have to go and look at it myself by law. That is the requirement that this law makes. So the changes of practice for chronic non-malignant pain have been unchanged, and it's still the 3 to 7 day limit for prescription Schedule II opioids still applies for acute pain, non-chronic malignant pain. Very good. So the first thing that we're going to talk about is the concept of total pain. The concept of total pain is a term used to describe the psychological, social, emotional, spiritual, and physical experience of pain. Beyond its physical dimensions, pain threatens the intactness of a person. Physical pain may be directly caused by illness and treatment and comorbidities, but existential or spiritual pain arises from the impact on a person's sense of control, identity, justice, and meaning. So a good example of that, and this is really important when we're talking about acute versus chronic pain. From a psychological aspect, it's easy for me to understand and reconcile the fact that I have pain, acute pain, because there is an injury to a tissue injury. But when it comes to chronic pain, when the tissue is already healed, how am I able to reconcile the fact that I'm still in pain because of it? So chronic pain. So it's pain that typically lasts more than 3 months or past the time of normal tissue healing. Can be resulted of underlying medical disease, injury, medical treatment, inflammation, or unknown cause. chronic pain is not a vital sign. So it goes back to 1990 when we were saying it as a vital sign. It's not a vital sign. It's a common pathway, the end result of numerous biopsychosocial contributors. In population with solid tumors, the prevalence of clinically significant chronic pain has been determined to be between 15 to 75%. So what that means, so in the most recent data, it's actually looking at around 40%. So between 15 and 75. So the considerations for treating chronic pain. Opioid titration protocols that we recommend for patients with acute pain don't necessarily work as well for chronic pain. The most effective treatment for chronic pain may be the result in immediate substantial reduction, may not be the immediate substantial reduction of pain intensity. So this is probably one of the most important points that I want to make across in this lecture today, is that understand that pain intensity is not always going to be our goal when treating chronic cancer pain or chronic pain in general. Unlike for acute pain, those with chronic pain should have pain intensity not as a primary outcome, but reduce in pain interference, improve daily function, and reduction in suffering. So we'll talk about the different types of pain. We have neuropathic, somatic, visceral, and I added cancer-related pain because it's a combination of two of those different types of pain. In the neuropathic pain, obviously affects the somatosensory system. It's described as burning, electric shock, tingling, increased sensitivity. The treatment and the primary treatment shouldn't necessarily be opiates. You use neurologic agents such as gabapentin and Lyrica and things like that. Opiates will have and play an important role in treatment of neuropathic pain, specifically for cancer-related neuropathic pain. And there's a lot of research coming out right now saying that methadone has a significant impact in treating neuropathic pain. Somatic pain usually affects skin, soft tissues, bones, and joints, has a particular location, and is usually intensified with movement. It's described as aching, stabbing, throbbing, or squeezing. And for those, you should be considering short-acting opiate formulations, NSAIDs, or combinations of opiates and non-opiates, like, for example, Percocet. Visceral. It's a compression, obstruction, or ischemic of a visceral organ. It can affect hollow tissues, or hollow viscous, or organ capsules. It's described as cramping, gnawing, squeezing, or pressure, or sharp or stabbing. In these cases, you have to start thinking about considering long-acting opioid formulations for the treatment of those diseases. Cancer-related pain. Like I was saying before, cancer-related pain, cancer-related bone pain is a combination of two. It's a combination of a somatic pain and a neuropathic pain, the way it is described, the way it's characterized, and also the way that it should be treated. When you're treating cancer-related bone pain, you pretty much have to throw the book at them. So you have to give them the neuropathic agents, you have to give some form of opioid formulations, but they do preferably work best with NSAIDs as opposed to opiates as primary treatment. Those are the patients that are seen in the hospital, that they're getting IV Dilaudid, and you're increasing the IV Dilaudid dose, and you're still not getting pain improvement, but as soon as you give them a dose of IV Toradol, the pain magically goes away. All right. This is a big graph. There's a lot of information here, and I'm going to try to synthesize this as much as possible. There is no universally accepted way to classify cancer pain syndromes. This one's the one that's been used more frequently, and it divides pain into related to the tumor versus related to the treatment. Inside related to the tumors, as you can see, you have the different types of pain. The neuropathic pain, the visceral, the somatic pain, the pain associated to soft tissue disease and paraneoplasia. And related to the treatment, you have chemotherapy, radiation, or surgery. Let's try to make it a little bit more simple. And pain syndromes in cancer, you want to try to differentiate versus frequently requiring opiates or infrequently require opiates. Chronic pain due to advanced cancer, you're going to frequently require opiates. Acute pain due to cancer complication, and postoperative pain and radiation chemotherapy-induced mucositis, those frequently will require opiate use. Infrequently would be neuropathic pain, non-malignant pain, acute musculoskeletal syndromes, and small procedures, dental procedures, and diagnostic procedures. So what are the key assessments for key objectives of pain assessment? You want to make sure you characterize the multiple dimensions of pain to formulate an understanding of the nature of the pain, characterize the effect of pain and quality of life domains, clarify the extent of the neoplastic disease, plan treatment and prognosis, clarify the nature of the quality of the previous testing and treatments, elucidate medical comorbidities, psychological comorbidities, and to identify needs from palliative care and interventions. So how do we do a pain assessment? Probably the quickest and the first thing that you should be doing is a PQRST, describe on how to effectively describe the pain that the patient is suffering. So P, the precipitating factors, Q for quality, radiation, site and severity, and the timing and the treatment history. It's important for us to identify when speaking about the timing as it relates to the pain, but also as it relates to your treatment that is being applied to the patients. Pain assessment. Okay, so we've seen these are called the Wong-Baker faces, and I think everybody's seen them. You should have seen it. It's in the wall of every single room at UHealth Tower. The problem with this is, though it has been very validated and very used, it's not a good, effective way of objectively determining how that patient is experiencing pain. There's a lot of variation. Obviously, a pain that's at a level 8 for me might be different for somebody else that is experiencing the same amount of pain. So we have other strategies. This one's called the Edmonton Symptom Assessment System. It's something that we use quite frequently in palliative medicine because it looks not only as pain, but it looks at other symptoms that could potentially be palliated. And the big thing that you want to do with this specific assessment is you want to make a correlation between this pain in itself and how it relates to the other symptoms. So if you have a pain at a 10 and everything else is at a 2, then you know that there is a discrepancy there at how the patient is assimilating that pain. So is something called the Minkowski Pain Scale, and it was devised in 1995. It gives us a more descriptive analysis on how we describe each grade of pain from 0 to 10. I'm going to move on because this is the one that I really want to focus on, and this actually has a functional description of the pain and how it relates to the grade of pain, but it also gives us an understanding of what each grade means. Specifically for chronic pain, like we mentioned before, we're looking at how it impacts functionality as opposed to the intensity of pain. So we have the mild pain. As you can see here in functionality, it interferes with most activities, but the patient is able to adapt to the pain psychologically or with use of prescription medications or devices. It's the grade from 0 to 3, and you can see here it goes from a very mild and light pain, which is a 1, all the way down to a noticeable or very noticeable pain, but the patient is able to adapt to it, is able to overcome that pain. Moderate pain, it interferes with many of the activities, requires lifestyle changes, but the patient is able to maintain his or her independence, which is a big important component of this. Right? The ability to maintain independence is going to be a big important decision when it comes to dealing with these pains. It goes from a grade of 4 to a grade of 6, these are all very strong, deep pains, but as you can see, the patient not able to completely adapt, but is somewhat able to adapt, leading all the way to a 6, where the patient is having significant trouble holding a job or, more importantly, maintaining and performing tasks. Lastly is going to be the severe pain, and that's when the patient is unable to engage in normal activities, the patient is disabled and unable to function independently. And it goes from a pain of 7 all the way to a pain of 10, which is unimaginable, unspeakable, unbearable pain. Which is all the way down here. Excellent. So, considerations for long-term opioid therapy. And this was put out by the CDC. It's actually specific for primary care physicians. It was created for all types of chronic pains, not specific for cancer pain. But I think some of the points that are being put forward here are interesting for us to see. To set realistic goals of pain, function based on diagnosis, check that the non-opioid therapies have been tried and optimized, discuss benefits and risks with the patient, evaluate the risk of harm and misuse, including identifying risk factors, checking the PDMP or E-Force in the state of Florida, check for urine drug screens. Set criteria for stopping and continuing those medications, and assess the baseline pain and function. schedule initial reassessments every 1 to 4 weeks, and moving there forward every 4 weeks or so. And start with short-acting drugs and long doses, the lowest dose possible available in that labeling. So, like I said before, this was created for non-cancer pain, and this last point, it might not be specific for the cancer pain. Okay, so the different types of characters or categories and ways that we can manage pain. So we'll start with the pharmacologic. As you can see, opioid analgesia is still the first one on the list, and it's probably the mainstay of treatment of cancer pain. You have non-opioid analgesia as well, including anything from NSAIDs and now moving forward with cannabinoids as well, which is growing in this specific population. You have interventionals, which include injections and blocks for analgesia, rehabilitative, like physical modalities such as ultrasound, therapeutic exercise, occupational therapy, hydrotherapy, heat and cold therapies. Psychological educational interventions, cognitive behavioral therapy, relaxation techniques such as guided imagery, and hypnotherapy. Neurostimulation that could be transcutaneous, transcranial, or hypnotherapy. And lastly, the complementary, alternative, or integrative medicine, including acupuncture, massage, physical movement, physical therapy, art therapy. Now, when it comes to all the studies that have been done specifically for this last one, and there's always speaking specifically on how it affects the intensity of pain, the data is not well. It doesn't show that there is a significant impact in treatment of intensity of pain. But because we're not talking anymore about the intensity of pain and more about the functionality of the patient that's dealing with that pain, there is a lot of things that can be done from that standpoint as well. So how do we select a drug? We have to look at the characteristics of the pain, the characteristics of the patient, and the characteristics of the medication. Specifically of the pain, the first thing that you need to do is you need to identify, are we dealing with an acute pain or are we dealing with a chronic pain? What type of pain are we dealing with? And what is the intensity and what's the functional impact of that pain to the patient? The characteristics of the patient, previous experience to opioids, recent exposure, age and body weight of the patient, renal and hepatic disease. What are the characteristics of the medication? Okay, so we go into the pharmacokinetics of the medications, including the absorption and all the different modalities that we have available, be that oral, parenteral, transdermal, the distribution of the medication, and how lipophilic. As you know, opioids in general, not in general, they are all lipophilic agents, but there is a grading system as to how lipophilic they are. The more lipophilic they are, the higher the volume of the distribution, they'll act faster and be stronger as well. Metabolism always involves the cytochrome P450 and 2D6 and 3,4-A. And the excretion happens through the kidneys except for methadone. Methadone, the important thing is that it doesn't have metabolites and it is excreted through the bile. Specific side effects like QT prolongation in methadone and renal disease that you want to avoid with oxymorphone preparations. Okay, so the WHO in 1996 decided to create this grading system to determine how we should proceed in dealing with specific pain and how we should decide which pain to use. This is called the pain relief ladder. And what they were looking at in 1996 was to see, based on the intensity or the severity of pain, and they classified mild, moderate, and severe, what medications should be used. The difference is that in 1996, the formulations of the different opioids and medications in general that we had available are not even half of the ones that we have now. So not only do the formulations that we have for natural opioids, such as morphine and codeine, can come in lower concentrations and lower doses, making them available for the level 1 or mild pain, but also the extended release pain medications and regimens that we can be used at this point. So it's still there, it's still being referred to in papers and in books, but it's not necessarily something that we want to follow on a consistent basis, but I had to bring it along. So the Equi analgesic opioid dosing. Took me a while to figure out that word, Equi analgesic, but here it is. So this is probably one of the most important things that we do from a palliative medicine standpoint, and it's all based on morphine, specifically on oral morphine. So whenever you're trying to consider which medication you're going to be using, you should look at how it relates to oral morphine and how you convert your daily opioid treatment to that oral morphine. So what we do on a consistent basis is we identify which opioid we're using. Let's say, for example, we're using Dilaudid, right? That's a class favorite. We convert, be that the IV Dilaudid or the PO Dilaudid, into how much that equates to the morphine, oral morphine equivalent, and that gives us an idea of how much pain medication units are being used on a consistent day basis. So why are we using more and more methadone? So it acts on the NMDA receptor as well as in the mu-specific opioid receptor. It may provide analgesia for the neuropathic pain as much as it does for other types of pain. It's fairly long half-life. So the half-life average is around 24 hours, but it can be anywhere from half a day to 5 days. And a steady state is reached to 5 to 6 times half-life. So around the highest that's been described is over 190 hours for a half-life, but it ranges, most of the patients is usually for 1 day. It can be dosed either 6 hours, 8 hours, or 12 hours, and it's cost-effective when it's compared to all the other opioid agents that we have available. So it's cheap, it works well, it works for different types of pain, and it's slow to titrate, but once you get it titrated, it's actually very good to use. It's also very effective at mitigating the cravings associated to addiction and concerns for misuse. So breakthrough pain. So we're dealing specific with pain, intervals of pain. It's also been called, so the breakthrough doses or rescue doses or escape doses, all of those mean exactly the same thing. It's reported to 40 to 80% of patients dealing with cancer. So 80 to 40% of people dealing with cancer will at some point have a breakthrough episode of pain, be that in association with chronic pain or without. Usually it's recommended to use a shorter acting drug formulations, and depending on the dose required, you should be considering opioid versus an opioid, non-opioid combination. If you're using the oral formulations, you should begin with 10 to 15% of your daily dose every 2 hours to determine how much for breakthrough dosing you should be using. So 10 to 15% of your daily dose every 2 hours. If you're using IV formulations, 50 to 100% of your daily dose, and you can do that in 10 to 15 minutes, every 10 to 15 minutes, until that pain control is achieved for that specific breakthrough pain. So the types of breakthrough pains, you have 3 different ones, and those are the first thing that you need to identify once you're dealing with breakthrough pain. Is it incident, is it idiopathic or spontaneous, or is it end-of-dose failure? So incident is activity related and has an identifiable precipitant. So for those, you want to try to pre-medicate your patients. Once you've identified what the precipitant is, you try to preemptively treat that patient and to avoid those symptoms. When it's idiopathic and it's spontaneous, and this is probably one of the most frequent ones when dealing with cancer pain, is you don't necessarily know when it's happening, or it's happening frequently on a consistent basis throughout the day. And you should try to use short-acting rescue if possible, but the best thing to do is to optimize your baseline regimen. So you want to make sure you increase or treat that with your long-acting medications. The end-of-dose failure, it's exactly what it means. It's that the pain or the pain relief being provided by the medication or the regimen that you're using is not lasting long enough for you to control that pain. And what you want to try to do is you're either going to increase your dose or you're going to shorten the time between the baseline, between the regimen, specifically treating it with the baseline. Opioid rotation. So when are we going to want to rotate the opioids that we're using, or when are we going to try to use a different type of opioid? So it could be when the side effects associated to your regimen are either undesirable or intolerable to the patient, or because you're not providing significant pain relief associated to the regimen. It's going to do a 2-step approach. So step 1 and step 2. So in the step 1, you want to select a new drug based on the prior experience. So you want to use the pain regimen that you were using prior to determine what your new one is going to be. You're going to use the Equi analgesic dose graph that I showed a couple of minutes ago and use that to formulate your new plan. If you're switching to other opiates that are not included, methadone or fentanyl specifically, you want to make sure that you do an automatic reduction of 25 to 50%. Specifically in those patients where the side effect is the problem, is become intolerable and not necessarily the pain, you want to use that reduction. Step 2. So it's based on the assessment of pain severity to increase the dose by 15 to 30%, obviously. So this can eliminate this. So if it's an intensity problem, you might not necessarily want to reduce, might want to do a 1-to-1 conversion. You assess the response and titrate accordingly, but also when you're doing that and it's because the uncontrolled pain, you're going to want to add supplemental doses of that. And that supplemental dose is going to be calculated by 5 to 15% of your total daily dose. So what are going to be our risk factors for the misuse of these medications? It's believed that 20% of patients, or 20% of cancer patients, will have a high risk of aberrant behaviors and could develop potential substance abuse. Most risk factors, the most common and most significant risk factor is actually a history of alcoholism or alcohol abuse. In the general population, there's approximately 8% incidence of alcoholism. Specifically in the cancer population, it increases to 17%. We don't know exactly why that is, but the working hypothesis is that alcoholism in itself is an increased risk of developing cancer, and as a consequence of that, it increased risk of misuse of medication, of these specific medications. So amongst the advanced cancer patients, we do the CAGE test to determine if they are at risk of alcoholism, and those are positive. When we correlate that to smoking, people that have never smoked and are CAGE positive are going to be about 3%. The former smokers are 12%, and the current or active smokers are 42%. So not only does it correlate with misuse, but it correlates with the use of other things such as smoking. And also a similar rate with street drugs. So 3% with never used or never consumed street drugs. Former street drug users and current street drug users are 3, 16, and 33% equivalent. Okay, so these are three important terms that it's important for us to identify when speaking directly about risk management of opioids. The first term is addiction. So addiction is a primary, chronic, and neurobiological disease. It's a disease. It's developed by its development and manifestation are influenced by genetics, psychological, and environmental factors. It's characterized by one or more of these behaviors, which include impaired control over the drug use, compulsive use, and continued use despite harm caused by the medication, and also by the craving. Physical dependence is a state of adaptation indicated by medication class-specific withdrawal syndrome that can be produced by abrupt sensation, rapid dose decrease in blood levels of the drug, or administrations of an antagonist. The important thing to remember is this: physical dependence and addiction do not mean the same thing. And you have to be very cautious when speaking about these specific things, because the fact that the patient is suffering from physical dependence and is having some of the symptoms associated to physical dependence and cravings doesn't necessarily mean that the patient is addicted to the medication, and it's easy for us to stigmatize those patients. Lastly is pseudo-addiction. So the pseudo-addiction is an iatrogenic syndrome with the behaviors that mimic addiction and are driven by unrelieved pain. It's caused by inadequately prescribed analgesics, leading to patient demands for opioid analgesics that the care team deems to be excessive. When patients are provided adequate dosage, all of those symptoms and all of those behaviors go away. What is important to remember is you can have a patient that has pseudo-addiction and addiction at the same time. Okay? Now, if a patient has pseudo-addiction, it doesn't necessarily correlate with an increased risk of developing addiction, but it's important to understand that those patients can have both of those things happening at once. Okay, so this study was done in 2012 when all the prescription was at the peak and at the highest, and they tried to see in a small group of patients, a little bit less than 200 patients, how many patients deviated from their opioid prescriptions versus the patients that did deviate. And only a small amount of patients in this study, which was 19 out of close to 200, or almost 10%, did deviate from there. And there was not a very specific or a significant correlation, and I think that basically because of the power of this study was so short, to determine if there was a specific age population that had a higher likelihood to deviate from those opioid prescriptions that were being prescribed. So behavior suggestive of non-medical or aberrant opioid use. And we all know this. We all see this in our clinics. If we are prescribing opioid medications, you'll get a patient that has at least one of these, and it'll make you be concerned about it. So frequent unscheduled clinic visits or phone calls for refills, self-escalating opioid use, frequent emergency room visits for opioids, seeking opioids from multiple physicians, requests for specific opioids, report stolen or lost opioid prescriptions, family member experiencing concerns, obtaining opioids from non-medical sources such as stealing and selling, requesting opioids for insomnia and not specifically for pain, so insomnia and anxiety, and abnormal urine drug screens and discrepancy in the pill counts. Okay, so how do we screen for these patients? There's three different screenings that we generally use, and the one that has the most sensitivity is actually the physical interview. So the physician interview has a sensitivity for identifying opioid misuse at about 76%. Then you have these other screening tools that are available. The first one is the SOAP, and that one has the highest one below the interview. It's about 73% sensitivity. It takes less than 5 minutes. It should be administered by the physician. And if you have a score of 4 or more, that identifies that patient as having a potential for misuse or aberrant behaviors associated to the opioid medication. The other one was very similar to that is the opioid risk tool, and this should be done on all patients. So this should be, we'll talk about this a little bit later, but one of these screening tools should be done on every single one of your cancer patients when you're addressing it and trying to start the medication for opioids. I know you're smiling, I know why. So we'll do this very quickly. So you have a cancer patient that comes in and reporting pain. Like, we identify if the patient is going to require pain or not require pain. If it does, or requiring opiates or not requiring opiates, this patient has been identified as requiring opiates. You do the quick screening, it takes less than 5 minutes, and now you identify that the patient has a high risk or a low risk. What the literature says is the population is going to be about 80% here, 20% here. When it has a 20%, these 20% or the high risk of developing non-medical use of opiates, that's when you have to be aggressive about avoiding the misuse and preventing those things. So one of the things that we can do, and one of the things that's been done before, specifically for in pain clinics, are the controlled substance agreements. So we changed the name on it. It used to be called pain contracts or narcotic contracts. The reason for that is the perception of the patient that they're going into a potential litigious type situation by signing that contract. The idea, by changing the name to controlled substance agreement and not a contract, is that you want to make sure that you're involving the patient in these discussions. So it goes back to our discussion of the shared decision making of these patients. You want to make sure that you're involving them in these discussions. So the objective is to improve the adherence, obtain informed consent, outline the prescription policies of your practice, and to mitigate the risks. Urine drug screens. So you have the different types of urine drug screens that are available in them, that are available to us. You have the screening one and the confirmatory. The screening one uses immunoassays, and it's looking for the parent drug or the metabolite. The confirmatory urine drug screen, which is generally a mass spectrometer, and it's used for specific drug testing. The limitations of that test is it is unable to tell which drug has been ingested, the amount of drug that, specifically the amount of the drug that's being ingested. The detection time is 1 to 3 days, but as we spoke about, a lot of these medications are very highly lipophilic, so they adhere to the adipose tissue, and it changes the amount of time that medication can stay into your system, and therefore can change the way that we are able to diagnose these. And it is unable to differentiate, and this is an important part of it, it's unable to differentiate between the natural opioids versus reliably detect the synthetics and the semi-synthetics. As you remember in the beginning, we were talking about the major issue that we're having now with the semi-synthetics and the synthetics. Okay, I am not going to teach you guys how to tamper with urine drug screens, but I am going to tell you exactly how you can tell if the drug screen has been tampered with. So you should know that the temperature is between 90 and 100 degrees Fahrenheit for normal urine. The pH should be between 4.5 and 8. And the urine clearance is less than 20 milligrams per deciliter is considered dilute. Lastly, if it's less than 5, it's not likely human. Okay? So if you have a creatinine clearance at less than 5, look at the dog, don't necessarily look at the patient. Okay. Oh, you might make a case for if you're going through the trouble of getting your dog to pee in a cup so that you can get more opiates, you might be deserving of an extra dose of opiates. So, abuse deterrent opioid categories. So what are the different deterrent type of formulations that we can use to prevent or to try to mitigate those behaviors? And we have physical or chemical barriers, which are usually polymers at high resistance coatings and gelling agents that can resist mechanical or dissolution. So if these pills are being crushed, they don't necessarily have the same effect. And if you try to dilute them so that you can inject them, they'll turn into this viscous gel that won't allow you to inject that medication. So the combination of agonists and antagonists, these are designers aim to sequester the antagonist so that it becomes active if crushed. So it works normally, but if you try to crush, as soon as you try to crush it, the antagonist becomes effective and you no longer have the same potency as you were expecting from the previous doses. Aversion. So some of these medications actually show that there's an aversion effect, such as irritation to the mucosa. This is naturally present actually in methadone. So methadone, there is no formulation for transdermal methadone, and the reason for that is it causes irritation to the skin. They were able to create that and turn it into other opiates that will have the same effect. Delivery system, obviously the sustained release and the depot injections and the implants are things that are being used as a potential abuse deterrent opioid category. Lastly, the new molecular entities and prodrugs requiring enzymatic activation. So these are examples of abuse deterrent opioid formulations that are available. Most of these available in the market right now. So you have the OxyContin, and probably this is the most common one, and this is the one that we use the most, or extended release oxycodone. This has a physical and chemical barrier deterrent. It's difficult to crush, and if you were to try to dissolve it in alcohol and water and any of those other preparation, it turns into that viscous gel, and I won't be able to inject it into myself or to my patients. Problem with it's 2 times the cost of long-acting morphine preparations. Okay. The next one, the oxycodone and naloxone combination. It's an agonist-antagonist combination. The naltrexone is released when it's crushed. So you get the medication, you crush it, the naltrexone appears, and it's no longer as active and it works as well. This one's not available in the United States right now. Next one is the morphine and the naltrexone extended release. It also goes back to the same principle of the naltrexone gets released. This one is available in the market right now. It's 7 times the cost of long-acting morphine. The hydrocodone extended release, physical and chemical barrier detergent, when crushed, causes the viscous, is the same principle, 8 times as costly. Lastly, the oxycodone extended release, which is similar to the OxyContin, has the same effect, but it's 4 times as expensive as opposed to being 2 times as expensive. Actually, there is a combination between the oxycodone and the naltrexone, but that also is not available in the United States right now. But if it were, it'd be expensive. So, when do we use naloxone on our patients, on our cancer patients? So it is still the exception rather than the use and treatment with cancer patients, especially in the palliative medicine services. The reason for that, there's always a concern that bystanders might perceive, or people that are caregivers or people that are caring for these patients that might perceive that physiologic changes that are associated to the progression of the disease or progression of the cancer can be perceived as a potential mistake for overdose. So progression of the disease can sometimes look like the pain is uncontrolled, and therefore they might administer the naloxone, and then you have a worse patient now that has severe uncontrolled pain and also a progression of the disease. Okay, so what are the risk factors for related fatalities in cancer patients? So we talked about high dose and a high daily dose, which was morphine equivalent dose of over 100 milligrams a day. The state of Virginia actually requires that if you have a morphine equivalent dose of over 60, it is by law you have to give your patients a prescription for naloxone. So there are states that are being more aggressive when it comes to administering and giving these patients naloxone, one of them being the state of Virginia. So the use of methadone has been postulated as a risk factor for increase in related deaths because methadone specifically actually shown more death cases, but specifically for the cancer patients is not necessarily the case. The use of benzodiazepines and antidepressants in combination with the opioids is a risk factor. It's a risk factor, but specifically for cancer patients, it might not necessarily be a risk factor because benzodiazepines and antidepressants are used in combination and are adjunct agents using with treatment specifically for cancer-related pain. So the fact that they are risk factors is definitely considered a risk factor, but in practice, it's not necessarily the case. The previous history of unintentional and intentional overdose, that's definitely something that's there, and it should be considered a risk factor. A history of substance disorder, specifically alcohol, like we spoke about before, and a history of chronic pulmonary, renal, or hepatic disease puts the patient at risk of having fatalities, more specifically because how the patient's specific physiology or the pathophysiology might interfere with our medications or escalation in pain medications. And a recent history of incarceration. Okay, so I think I talked too fast, but I got here before I expected. So in summary, opioid therapy is still considered the mainstay of cancer treatment and cancer-related pain. There's a lot, and I see a lot of this very frequently, that there's a lot of opioid phobia, specifically in our colleagues that are dealing with cancer-related pain. And with all of these changes, like the HB 21 law that's come into effect, and a concern to prescribe these medications. They're still the mainstay treatment of pain, but it should always have an adjunct treatment therapy associated to it. And you should always follow that rule of determining if this is acute versus a chronic pain like we talked about before. Aberrant behaviors of abuse can be present in cancer populations, and therefore screening is needed. Screening should be performed on every single one of your patients, including and specifically for cancer patients. A lot of them, the screening is not necessarily going to be positive, but you'll at least be able to identify those 20%. The big problem that we're having in the palliative care world right now is these patients that we're dealing with that continue to see us in survivorship because they now have aberrant behavior and they no longer have the diagnosis of cancer. They're considered to be in survivorship. So discontinuing and de-escalating those pain medications on those patients has become a challenge and is something that we need to address. So the current deterrent monitoring and interventions that we have available are not specific and not the best for this population. So, as we said, the pain contracts are not necessarily the best idea for these patients, and the use of urine drug screening has not necessarily been a model that we want to necessarily follow with the cancer patients. The other part of this is, as we notice an increase of cannabinoid use specifically in the cancer-related population, what is that going to change? How is that going to change the way we perceive and we use the urine drug stream? Before, it was perceived if you had a positive for cannabinoid, that's an automatically assumption that these patients are misusing and potentially using other medications. With cannabinoids becoming assuming a role of more of an adjunct therapy, how is that going to change the way that we think about it? Okay. And I left 5 minutes on that. Okay, so that's okay. Thank you.
Thank you, Dr. Soares, for an important topic that was well presented. I'll begin by just asking maybe one question. So have you run into difficulty with the insurers in terms of dictating based on cost, which opioid or synthetic opioid you can prescribe in cancer-related pain?
Absolutely. So we still have to go through the same process of prior authorizations for a lot of these medications. The big one that we have, the big problem is the transdermal fentanyl patches. We have to go through a lot of hoops. A lot of specific insurances don't want to give that medication, and so that has created an issue. And also the deterrent type formulations that are very high in cost, which could potentially play an important role for cancer patients, are not being made available to us on a consistent basis. So yes.
So, Dr. Rosenblatt.
I'm just curious about your approach to the management of perioperative or acute pain in these other patients setting in prior addiction.
So
Repeat the question. One of the things that's happening today is a historic event due to thanks to Laura Pinzon and Amar Deshpande and Stephanie Brown. We having live streaming to the clinics of Grand Rounds today. Hopefully it'll be available to everyone. We know there are at least 3 people watching. So I don't know how well the question has been heard by the people in the TV land. So if you could just repeat the question.
So the question, if I can repeat it now, is how do we deal with specifically procedural pain or post-operative pain or post-procedural pain, and how that impacts patients that we're dealing with that have potential for misuse and or prior history of misuse. So we know, and we have to be aggressive when treating post-procedural pain. We know that it has a short half-life when concerning, and we attribute that more of an acute pain lasting 1 to 3 days at the most post-procedure. So we are aggressive at treating that specific type of pain, but we're also as aggressive as to prescribe as we are as de-escalating that acute increase. So post-procedural day 1 to day 3, we increase, but after day 3, we start de-escalating and going back to baseline.
How effective is ketorolac?
Repeat the question.
How effective is ketorolac? And then I think it's effective. There's a place for it. My general feeling for it is it's almost like a last resort when you're getting to the point that you don't have it. Well, it depends on the procedure. I'll take that back. It depends on the procedure. If there's a lot of soft tissue joint involvement and bone involvement, but with a lot of these procedures it plays a major role. Take that back.
Question in the back, yes.
On a similar note, in our patients that have a history of misuse or high risk for misuse, also have advanced stage cancer, in the real world, how does that affect our prescribing patterns? Do they really hold opioids or
So the
Repeat the question.
So to repeat your question, in patients specifically dealing with advanced cancer that have high requirements and high dose requirements for pain, how do we mitigate in that, and should we start
Who have had a history
who have had a history,
or are at high risk for developing?
abuse?
right? And how do you treat those? I think that other than calling a palliative care consult, right? I'm sorry. I had to put that out there. I'm sorry. Other than calling a palliative care consult, I think that you have to be aggressive and you have to remember how is the pain impacting the patient's functionality and the patient's ability to maintain his or her independence. So you have to make that distinction. Is the advancement of the cancer that is having an impact on the functionality, or is it the pain associated to that advancement that's having the issue? And then decide if you're going to increase or maintain dose or change the dose.
Thank you very much, everybody. We'll see you next week. Thank you.
You liked it? You said it was good?
Excellent.